The choice between obinutuzumab and rituximab is an interesting one. In my practice, I choose obinutuzumab really for the majority or all of my patients when I'm combining the antibody with chemotherapy. Now, the rationale for that is the GALLIUM study. The GALLIUM study was a randomized phase 3 trial in which patients were randomly assigned between either rituximab or obinutuzumab, and both antibodies were combined with a chemotherapy partner that was CHOP, CVP, or bendamustine. And the results of that study showed that the 3-year progression-free survival was a little bit higher with obinutuzumab, and at the same time, obinutuzumab caused a little bit more toxicity. Knowing that that's the data that we have, I think obinutuzumab is probably a little bit more effective of an antibody in follicular lymphoma, and for that reason, I personally choose it as the antibody that I use with chemoimmunotherapy in my previously untreated follicular lymphoma patients. That said, I am probably in the minority of oncologists in the US in that regard. I'm told that the majority of oncologists choose rituximab, not obinutuzumab, as their initial treatment. Why is that? Well, I think one reason might be rituximab has been around a long time and oncologists are very comfortable with it. Obinutuzumab does add a little bit of extra toxicity. Cost might be a factor in that, perhaps obinutuzumab as the newer agent is a little bit more costly, and certainly in the upcoming era that we are entering into now with biosimilar versions of rituximab, that cost differential might be more significant than it has been until now. And so for all those reasons, I think most doctors are still choosing rituximab. I don't think anybody thinks that's unreasonable. It's still the go-to antibody for most people, and still a very reasonable choice. So, but for me, I personally will generally choose obinutuzumab first. As I mentioned sort of early on, one of the prognostic issues in follicular lymphoma is the so-called POD24, or the patients whose follicular lymphoma progresses within 24 months of their initial therapy. That data set was generated from a review of the National LymphoCare study, and other data sets have found similar findings, namely that patients whose lymphoma relapses fairly soon, whether it be 1 year or 2 years from the initiation of therapy, have a less favorable prognosis than those whose follicular lymphoma relapses later. Unfortunately, we do not have the ability to predict in advance with a lot of accuracy who those patients are going to be. It would be nice if when a patient with follicular lymphoma walked in the door, we could say, oh, this patient has the features that make them likely to relapse within 24 months and therefore have a bad prognosis and therefore need a novel strategy. We simply are not very good at doing that. And that sort of speaks to the limitations of our prognostic models in follicular lymphoma. The FLIPI score is certainly not a perfect score at predicting who is going to have POD24, neither is the FLIPI-2, and neither is the so-called M7 FLIPI, which incorporates the FLIPI, the ECOG performance status, and the mutational status of 7 different genes that are known to have an impact on follicular lymphoma prognosis. So even the M7 FLIPI is not by any means a perfect predictor of who is likely to have an early relapse. And so we don't have a perfect prognostic score to be able to predict how patients are going to do. So we do the best we can, but reality is when patients come in the door who need treatment, we treat them, we cross our fingers, and we hope for the best. 80% of the time things work out, but about 20% of the time the patient still has a relapse within a couple years. We now know that many of those early relapsers do have transformation into a more aggressive lymphoma, large cell lymphoma, but not all of those patients. And some patients just have early relapse of their follicular lymphoma. At the ASH meeting in 2019, the results of the GALLIUM trial were analyzed using the M7 FLIPI. So to go back to the M7 FLIPI, it was initially developed using a data set where all the patients were treated with R-CHOP, and then it was validated using a data set where the patients were treated with R-CBP. And that's how the M7 FLIPI was developed. It had not been tested for its validity in patients treated with obinutuzumab or treated with bendamustine. And so a group of investigators took the patients from the GALLIUM trial who had been treated with obinutuzumab and bendamustine and looked to see whether the M7 FLIPI was an effective predictor of outcomes in those patients. And interestingly, the answer was no, that the M7 FLIPI was not a very good predictor of outcomes in patients treated with obinutuzumab and bendamustine. And so, again, that's one of the limitations of the M7 FLIPI, and it's part of the reason that the M7 FLIPI really is not used in clinical practice. I don't know any of the doctors with whom I work that send a genetic panel to look at the gene mutations in follicular lymphoma and calculate an M7 FLIPI on those patients. So I think right now the M7 FLIPI is more of a research tool, but not really that applied often in clinical practice. Also in the same study that was presented at ASH, the investigators looked at the role of EZH2 mutations, and they found that EZH2 mutations predicted longer survival or better outcomes in patients treated with CHOP or CBP, but that it predicted less favorable outcomes in patients treated with bendamustine. And so the corollary of that is the thought as well, when a follicular lymphoma patient comes in, should I check for an EZH2 mutation? And if they have it, should I make CHOP or CBP chemotherapy my backbone? And if they don't have it, in the 80% that don't have it, should I make bendamustine my chemotherapy of choice? In my opinion, this analysis was a retrospective one. It is not practice defining, and I think it's more of a hypothesis generating finding. And so I personally do not intend to change my practice and start checking for EZH2 mutations and picking my chemotherapy partner or chemotherapy backbone based on the presence or an absence of an EZH2 mutation.